I'm Thibaut Jacques. I'm working in the University of Lille in France with Professor Anne Cotten, who you may probably know. And I'm going to talk to you today about Cone-Beam city in emergency settings. So for those of you who don't know, Lille is the biggest city north of Paris. It's essentially located in Europe between London, Brussels, Amsterdam and Paris, so feel free to visit us anytime you want. And actually we have a pretty big hospital here, one of the largest in France, which is located only on one site with a lot of patients coming here every year, as you can see, and it was ranked among the best hospitals in France several years in a row. So we have 7 radiology departments there, and we have one common emergency radiology department with about 20,000 MSK X-rays a year, only for the ER workflow. And so how do we work? It may be interesting for you to know. So we have in this division 2 senior MSK radiologists and 2 MSK radiology residents who review every MSK X-rays that are performed by the ER workflow, and we see every patient. So we examine them, and we try to know if we want to do more exams like further X-rays or CTs or MRIs, and the patient only goes back to the ER with his or her reports and every exam done. It's only a weekday function, it's not the same on night shifts, of course. So that's why we chose to implement the device in this division 1 year ago, because we have a huge volume of patients going there. And we have now, as of today, I think we have like 250 patients, but about 85% of the patients come directly from the ER workflow and 15 patients from the trauma consultation. And so the device was available anytime the senior radiologist thinks it is helpful for the patient. And the only guidelines that were given to the radiologist were you have to choose between MDCT and CBCT. You can't perform both. So you have to judge based on your experience what you want to propose to the patient. So one of the first things I heard when we decided to put the device in the ER division was that, maybe ER patients are not the most easy ones because they are painful, they're going to move, you're going to have old patients, and so it may not be a good idea. But in the end, we succeeded in about every situation. So even the patients who are lying on the beds, we tried and succeeded. It may not be very conventional, but in the end, we managed to do this. So 1 or 2 days after we got the device, I'm going to show you 2 examples, 2 interesting examples. The first one was I think 30 years old woman who just fell on her feet. She was really painful, so obviously the plain radiograph didn't show anything. She was very painful, so we decided to perform a CBCT, and we had this obvious fracture there, which was also seen with this huge edema on MRI. So it was a clear example of the fact that you can rely on bone quality, and you can rely on what you see, because it's an undisplaced fracture you can miss if you don't have high-resolution images. The same for this obvious elbow trauma with a huge intra-articular fluid, and you know that there must be a radial head somewhere. You just don't see it. So we decided to perform CBCT, and once again we saw this tiny undisplaced radial head fracture. So those 2 examples just to show you that in emergency settings you need the high quality and you need the high resolution, whether it comes from a CBCT or from a ultra high resolution MDCT, but you need it. So after a 6 months period, we looked back, and we just wondered, what did we do in the last 6 months compared to what we were used to doing? And one of the interesting thing is that we noticed that our radiologists significantly perform less elbow exams. So when we asked them why did you choose to perform MDCTs when it comes to elbow instead of CBCTs, one of the main reasons is, elbow is difficult. Patients are really painful, they can't extend their arms, so yeah, but in the end, I'm going to show you why it's not a good conclusion. You can perform CBCTs even in painful patients and even in elbow patients. You don't necessarily have to extend their arm, because as it was shown to you before, it's a 20 centimeters, so people can go inside with a flexed elbow. You don't have necessarily to extend the elbow. So it's something we have to teach to our radiographers and to our radiologists. And one other interesting finding is that we I think we tended to image significantly more young patients on CBCT, and these really old patients more often on MDCT. I think there were two reasons for that. Maybe the first reason for having more patients on for really young patients is that in your head you have this voice telling you, CBCT is a low dose solution, so since it's low dose, I'm going to go for the young patients. It's I think something you do. In the middle there was no difference, but for the old patients, I think you may think that since they are old, they're going to move and it's not going to be fine. I think these are two bad examples. I'm going to show you why. She was an 83 years old patient. She had an acute elbow trauma, so obviously old plus elbow, you must think, okay, let's go for MDCT. And no, it wasn't a good idea. Even if we have a pretty good MDCT, this was clearly, you can't see anything. Why? Because I remind you that if you want to have a good image quality for elbow, you have to lift the elbow above at least the shoulder to limit body artifacts, and this was not possible in that case. So they tried once, they tried twice, you had this image. And so I was just here this day and just said, okay, let's try CBCT. And everybody told me, no, it's not a good idea, she's old, it's not going to be possible. So we tried, however, and it just took 2 minutes to have the patient position in the device and to have this acquisition. So there is no limit, actually. You can really perform interesting things in even old patients, even painful patients, even elbow patients. You can do everything. And then we saw this tiny radial head and diplex fracture. So we took a look at what it did change in our workflow. Since the patients are staying with us until the report is done, they stay quite a long time in the division. But we compared the CBCT period versus the MDCT period, and it led to a 20 to 30% decrease in the time the patient stayed with us in the radiology division. So it fastens the workflow. And I think this is the worst case scenario because actually, since we had no dedicated radiographer, most of the exams were performed by ourselves radiologists. So we had to do the exams on top of what we were doing in the division. So I think if you have a dedicated radiographer for that, your workflow can really, really be faster. This is a worst case scenario and this is different. But in the end, what's interesting, it doesn't take more or less time to interpret the exam because in the end, you just see the same data type that what you are used to seeing in MDCT. So it's the same. It's not longer, it's not faster, it's the same. So we took a look at the dose because you know that the literature is really flourishing with the dose information on CBCT, and you know that it's low dose solutions. So we compared CTDIs and DLPs, and the results were that effectively we found that CBCT dose levels were quite the same as MDCTs for low resolution or standard resolution, and they were 3 times or 4 times inferior to what we have for high resolution MDCTs, which is, I remind you, what you need to have in case of acute trauma, because you don't want to miss the small fractures. And this was an example of a cadaver who was imaged on CBCT, UHR MDCT, and standard dose MDCT, and you can see that the resolution is really close between CBCT and UHR, whereas the dose is more related to standard definition. So it is a very interesting solution. So after a course of 6 months, we just looked at so what do the radiologists want. And so, as you can see in the beginning, it was about a 50-50 solution. And in the end, radiologists tend to adopt the technique because they tend to prefer working on a CBCT for a 70-30 proportion. Just to finish with 2 examples to illustrate what I want to say. First thing is, we had this patient. He was, I think, 30 years old or 27. He came for acute sprain. He had a really painful lateral side, and we had this X-ray, where obviously we can see there is a peroneus bone. You don't know if it's a bipartite, if it's fractured. You don't really know, but he's really painful there. So we tried and decided to do a CBCT on this patient. And once again, you need the high resolution because here you can clearly see the small tiny fracture, the small tiny fragments that we also imaged in ultrasound bilaterally, and he was really painful there. So in the end, on the other side, there was a peroneus bone, which was normal. So we concluded that there was a small fracture on this peroneus bone. So you need a high resolution. And so last but not least, this patient, I think she was 16 or something, she came for a knee trauma, and as usual, you don't really know what happened. It was just a trauma, and then you do the x-ray, there's nothing special except this big intra-articular fluid. And most of these patients, actually, we don't perform cross-sectional imaging, except when there is a lipohemarthrosis that may let you think there is a fracture, but this wasn't the case here. So this patient may have directly go to the MRI 2 or 3 weeks later, which is common in France. But since we had the CBCT and since she was really painful when we examined her, we decided to give it a try. And so at the end we were right, because we found that it's a classical pattern of avulsion of middle aspect of patella and avulsion fractures of lateral aspects of femoral condyle, which is a witness that there has been a lateral luxation of the patella that was spontaneously reduced. This is interesting, but of course you could have had this kind of images with a high resolution CT, but in the end I think we did the CBCT mostly because we knew that it was less irradiant. Maybe we wouldn't have performed CBCT on this patient. She had an MRI, I think 1 week after, and we found this classical patterns of mirror edema. And usually these kind of patients, you see them in MRI, and you may guess that there may be some little avulsion here. So the CBCT here that was performed really helped us in seeing these microavulsions, and you know that these intra-articular loose bodies can worsen prognosis. So the second point I wanted to underline is that thanks to the low dose, maybe we will have more patients imaged, and it's going to be helpful to them. So my main point is that when you put a CBCT in a division like ours, in the end, what happens? You really lower dose for your population. You see high quality images. You don't really miss fractures, actually not more or not less than what you have missed on your ultra high resolution, but maybe you perform more useful exams for patients, and in the end the radiologists tend to adopt it. So thank you very much.